So, hello and welcome everyone to the Bridging Research and Practice Conference. I'm Constance Kim with SHARE, and this session is titled the Peer Specialist-Led Dental Health Initiative. And we are, a couple little things, we are recording today's all of the conference. So if you would please leave your name and contact information, your email in the chat, that would be great, because we will send you a survey and the recording will be available as well if you would like. If everyone attending would now please mute and remain muted unless you are called upon to speak, that would be great. Very happy to hear Adrienne Lapidos, and the link between oral health and psychological well-being is clearly established, leading some to declare that there is no mental health without oral health. That's from Kisley 2016. But oral health remains a significant area of inequity for people served in public mental health and medical settings. A community university government collaboration resulted in Oral Health for Community Workers, a brief e-learning module designed to improve the oral health literacy of peer specialists, peer recovery coaches, and community health workers, CHWs, serving underserved communities in Michigan. Adrienne Lapidos is a licensed clinical psychologist and clinical assistant professor at the University of Michigan Medical School, Department of Psychiatry. And we are very pleased to have you here. So I will turn it over to you. Thank you.
Thanks so much, Constance, and thanks for having me. I am just going to share my screen and start the presentation. Okay, so today's presentation is called Oral Health for Community Workers, and I'm going to be talking with you about how a collaborative team developed a series of e-learning modules designed for peer support specialists, peer recovery coaches, and community health workers to improve the level of interest in advocacy and level of competence and skills in managing oral health and dental care for the people that they serve. So this might seem like a bit of a swerve for some of you. So I'm going to tell you all about how oral health is really, really important to mental health and recovery, and how kind of a renewed focus on the importance of access to dental care and on at-home habits that support oral health well-being might be a really nice thing for people to add to their toolkits when it comes to supporting people they serve, especially individuals with serious and persistent mental illness or experiences in substance use recovery. So this is my core team here. Dr. Rulli down below is a faculty member at the School of Dentistry at the University of Michigan. And Mr. Mert Hershberger at the top is a certified peer support specialist who served on our steering committee for a number of years working on various oral health projects with us. So unfortunately, the two co-presenters couldn't be here today, and I'm going to present on their behalf, but you're very welcome to contact them if you have any questions. I won't quite be able to represent the peer perspective like Mert would have, but if anyone wants to be in direct contact with him, you are absolutely more than welcome to do so. So this is the article that Constance was mentioning at the beginning, this call to action, no mental health without oral health. And so what does this mean? It means that people living with mental health diagnoses are at very increased risk for oral health problems. And so this is actually a little known fact that these risk factors really accumulate, especially for individuals served in community mental health settings. Over at the top of the circle, you see medication side effects, and that's probably one of the biggest drivers. Many of you might be aware that dry mouth is a very significant side effect for a lot of psychiatric medications, especially those that people take for psychosis. But also antidepressants, all kinds of things produce dry mouth, and dry mouth is a big risk factor for oral diseases. Saliva is one of the protective factors in our mouths that actually protect us from getting the cavities. And when we don't have enough saliva, our mouth is not protected from cavities as much as it would ordinarily be. On the left, you see low access to care. So it's, different states run different types of Medicaid programs and, whether there's dental benefit or not. But in general, people have, already pretty low access to care when it comes to primary and specialty care, but even lower access to care when it comes to dental. And that's the case for the people we serve in safety net settings, but it's also the case for lots of other people. Just in general, Americans have poor access to oral health care. At the bottom, you see low income, and that's a risk factor as well, and also leads to greater treatment needs. It's hard to afford dental care. Dental care is very expensive. And even when some procedures might be covered by Medicaid, a lot of them are not. And people sometimes get into cycles where, if a state is running a pretty thin Medicaid program and a tooth extraction might be covered, whereas a tooth restoration might not be. So when you think about that, like, wow, imagine like the layers of disadvantage that start building up when people end up losing their teeth prematurely. That leads to not being able to chew those hard, healthy foods like fruits and vegetables. And then people end up chewing softer foods because it's easier to do that when you don't have a lot of teeth. And the softer foods tend to be the ones that are less healthy, like bread and fast foods and things like that. So you can see how like the layers of disadvantage to start building and building across all these different dimensions. Finally, I listed avolition here. It's a common symptom of schizophrenia and other serious and persistent mental health concerns. There's lots of other symptoms like just run-of-the-mill depression. It's much harder to take care of yourself when you're feeling depressed. A lot of the time, people's ADLs kind of are the first to go, and it's harder to shower, it's harder to get up and go, it's harder to get out of bed when people have severe depression. And so it just makes it harder to brush teeth as well. And when you look at this whole picture, you start to get a sense of why it's the case that people who are living with mental health concerns are at higher risk for oral health problems, and yet concurrently also have lower access to care. So when we were thinking through this problem, like, well, what are we going to do about this? We thought about the peer workforce, and we thought about what peers could do on kind of both sides of this problem. Improving people's access to care by educating them about what their Medicaid benefits are and how to access safety net clinics if they don't have good oral health coverage. That's on the one hand. And on the other hand, there's the self-care piece. So oral self-care, it's not the same as like coming up with like a diabetic diet. I mean, that takes like a lot of expertise. It takes like, you can't just like come up with one on your own. You need like, an RN or someone with like a scope of practice that like really knows like how to put together diabetic nutrition as a counterexample. Brushing teeth is not like that. A peer can very easily talk to someone else about brushing their teeth, flossing their teeth. They can talk about fluoride and how it's not actually dangerous. If you Google the word fluoride, actually the first couple of hits are like these really scary web pages about how fluoride is really bad for you. And of course, most of us know fluoride is one of the best public health measures out there in terms of improving people's oral health. So peers can do that. Peers can provide health education within their scope of practice. So, we don't want peers touching people's mouths. We don't want, peers doing actual dental exams. But can a peer provide health education about oral self-care? Absolutely, absolutely can. So that's kind of what got us thinking, like, how do we raise awareness in the peer specialist and peer recovery coach community about the importance of oral health, just like you would learn about diabetes, just like you would learn about the importance of exercise. You learn about oral health and dental care so that it occurs to people more regularly that they might want to advocate for their clients about access to care, or talk to clients about oral health habits. So we developed this partnership. It was a community university government collaboration. So we worked with the Michigan Department of Health and Human Services, specifically the person who oversees the peer workforce in Michigan was our partner in this project. We worked with a community advisory board of peer specialists, peer recovery coaches, and community health workers. We worked with the Michigan Community Health Worker Alliance, which is the organization that certifies CHWs in Michigan. And I'm going to tell you a little bit more about CHWs, what CHWs are, because I know some people in this room might not be familiar with CHWs. University of Michigan researchers in psychiatry and dentistry. So me and Danny work together like across disciplines. I'm in psychology, I'm in the psychiatry department. She's in the dental school. And so we worked together on this project. And we worked with a community organization called Michigan Peer Specialists United, and they're a nonprofit organization that is dedicated to advocating for the peer workforce in Michigan. And then we got a grant. So we got a grant from the Michigan Health Endowment Fund, which is a nonprofit organization in our state, to develop these learning modules. So here's like what we pitched to the funder and basically for the project as a whole, that we have these basically two separate workforces in Michigan that actually have a lot in common with each other, but don't often work together. And that is, on the one hand, the workforce that you all are very familiar with and know and love, and that's the peer support specialists and peer recovery coaches. Together, we call them in Michigan peer providers. So people in recovery from a mental health or substance use challenge, certified to support others with similar experiences. That's kind of the working definition we use in our state most of the time. And as you all well know, peers mainly work in safety net behavioral health settings like community mental health or VA. Now, CHWs are different. CHWs are frontline health workers who are trusted members of or closely connected to the population served. CHWs tend to be more on the public health side as opposed to the public mental health side. And often you will find a CHW working in a medical safety net setting, like a federally qualified health center, primary health center, primary care clinic, that type of setting. The huge advantage that peer providers have over CHWs in our state is that peer providers are sustainably financed while CHWs are not. So CHWs tend to work in settings where they are funded by temporary grants. When they dry up, the position either goes away or somehow the organization manages to cobble together other funds, either from the general fund or getting a new grant to support this workforce. But there was actually great news, actually hot off the presses this morning, related to the community health worker workforce, which is that there's a federal bill now, which is bipartisan, which is always nice to see, in support of the CHW workforce. So that suggests that maybe we're going to see evidence of financial sustainability among CHWs, in addition to the sustainability that has been enjoyed by peers for a number of years. So what these two workforces have in common is that they have unique knowledge of firsthand knowledge of the communities that they serve. So they've walked the walk, they've been in the shoes of the people that they serve. That's what these two workforces have in common, and that's one of their key strengths. What's different about them is that CHWs do not necessarily have a lived experience of mental health or substance use challenges. What makes them community workers is that they live in the neighborhood usually, or they might speak the language. They might be part of the community in some other way. But, on the mental health side, we define community in terms of the lived experience, having been there, having consumed those services as well. So part of what we hoped to do in this project is to bring together these similar yet different workforces and provide some training in how to support people's oral health within scope of practice. Like, again, being careful not to stray outside of scope of practice in this case. So our rationale was that oral health is not covered in most non-dental programs. So I'm a psychologist. The number of hours that I got learning about oral health when I was in graduate school was 0. I didn't learn anything about oral health in graduate school. And that's the case for most mental health providers. If you're a psychiatrist, you might get a couple of hours when you're in med school, but on average, non-dental providers only get 5 hours or less of any sort of education or training in oral health. So all of you in this room today might know more about oral health than, the primary care doctor that you work with potentially. Like, it's just a very, very neglected aspect of physical health. And in fact, you may have noticed when you ever go to the doctor and they look in your mouth, they look past the teeth to the tonsils. Like they'll open the mouth, they'll shine the flashlight in there, but they'll be looking at people's tonsils. They're not going to be looking for white spots or lesions or things on the teeth. And if they find anything, they're going to place a referral. They're not going to be able to handle the oral health problem within that office. So that was one problem, oral health not covered in most non-dental programs. So here was an opportunity to raise the level of training, education, awareness in the peer workforce in Michigan. The other problem was one that I was mentioning at the beginning of the presentation: low oral health access and low oral health literacy among individuals served by the health safety net. And that is exactly where CHWs and peers work. You know, like, what a great fit that the population that happens to be most at risk is the population served by peers and CHWs in my state. So our theory was trusted community members, such as peer providers and CHWs, can provide oral health education, linkages, and advocacy where the patients are at. And this is a critical piece. Most patients do not make it into a dental chair until the disease is very significantly progressed. And by then, the prevention, that ship has sailed. You know, people come in, like, by the time they're at the dentist, in front of a dentist, sometimes we're looking at a full mouth extraction after 15 years without any access to care. So we want this advocacy and education and information to be conveyed where the patients are at, which is their usual source of behavioral health care, you know, whether that's their CMH or wherever, or their primary care clinic in the case of the CHWs. And finally, the last rationale, again, something I've been talking about, is this critical piece, which is the financial sustainability. A lot of funders nowadays are very leery of funding new CHW programs because they're kind of like, it's not sustainably financed. This is kind of a non-starter. Where is this even going to lead at the end of your grant year? That is not the case for peer providers. So peer providers have enjoyed financial sustainability in Michigan and in many other states for a lot of years now. So this was kind of an argument we're making, that here's this wonderful, like, sustained workforce. Let's take advantage of this by raising awareness within this workforce about the importance of oral health and oral health advocacy and linkages. So here was our process. We got our funding in July 2019. We convened our community advisory board, which met quarterly. And again, that was a board consisting of, you know, nonprofit organizations and people with lived experience and CHWs. And then we basically got together and talked about, like, what do people need to know? What are the important topics that people need to know about oral health? Is it the importance of preventive care? Is it the message that it's never too late to do something positive for your oral health? Is it the at-home self-care behaviors? Like, there were a lot of different possibilities, and we basically sat together and we listened to our community advisory board and came up with these module topics. And thankfully we had Danny, who's our oral health expert, and she's a dental hygiene professor. So she was able to educate all of us about her perspective on what the most important topics were. So we kind of did up, like, a very, like, sort of skeleton presentation where we had, like, basically we used, like, a PowerPoint, and we put together some slides and a voiceover narrative about the topics that we wanted covered in these e-learning modules. And then we hired this wonderful educational designer that used software called Articulate 360 to put it together. So it's like an interactive, like, e-learning module. So you click play, you hear a voiceover, and you see the text moving across the screen. And sometimes you have to click on it to indicate, you know, that you understand what it says, or a drag and drop or something like that. So after they were developed, we piloted them with a few people, and then our community partners advertised the existence of the module through their professional networks, and then we launched them in July 2020. I'm going to tell you about the results of our program evaluation as well. So one of the things Danny and I felt strongly about is that we didn't want the university to kind of hold on to the intellectual property, because we felt like that would not be good for sustainability. So we kind of just formally gave it away to MISHWA, which is, again, the Michigan Community Health Worker Alliance. And they made a commitment to make these modules available for free for any community health worker or peer provider in Michigan. And that continues to be the case. So through MISHWA, these modules are accessible. And then also, thanks to our community partnerships, we started incorporating these e-learning modules into CHW and peer provider certifications as well. So now in Michigan, as this program is sustained, when you get certified as a peer and when you get certified as a CHW, you do get some oral health content through these modules. These modules aren't super long, you know, it's like basically 2 15 to 20 minute modules. But to me, that's just golden, because it means that people are getting way more oral health education and than they would ordinarily have gotten in these certification programs. And that puts people in a position where they can advocate and they can ask questions about oral health. And they do notice how important these linkages are and can refer people to dental care when needed. So this is kind of like the look and feel of what the modules are like. You would have text on the slide. You have this young woman who kind of like is like the character that like follows you over time in the e-learning module. And when you click play, you hear a voiceover explaining different oral health concepts. So, and if we have time, I can actually play you a little bit of these modules so you get a flavor for what they're actually like for the end user. So these were the topics that we collaboratively came up with in our group. Rationale for learning about oral health and quality of life across the lifespan, the connections between oral health and whole health. So a lot of people don't know that poor oral health is associated with adverse diabetes outcomes. It's associated with cardiac outcomes, with recovery from pneumonia. Oral health is really important to whole health, and it's all intertwined. And then we have a section on oral health and mental health, why it is the case that one's mental health is connected to one's oral health, how it's difficult to sustain a healthy sense of well-being if you feel ashamed of how your teeth look, or if you suppress the desire to smile when you're around people that you love because you don't want them to see your teeth. We talked about oral health terminology, signs of oral health problems, preventing oral health problems, and why go to the dentist. So those were the main topics in part one. And then part two, we took like the toolbox approach. So we talked with people about the home care tools that support oral wellness, and that includes toothbrushes, toothpaste, fluoride, and dental floss. We talk about oral home care practices and techniques. And then we emphasize this idea that my group and I have all been calling oral health recovery. And, this is a concept that's been so near and dear to our hearts. We've been working, on these topics for a number of years now, that the idea of mental health recovery was our inspiration when we talked about oral health recovery, because we really wanted to convey the message that it's never too late, but also that it's okay to meet people where they're at. So when we were looking for materials to use for our project, we noticed that most of the materials out there, like if you go to the American Dental Association website or anything like that, what you'll find is that everything has like this picture of a beautiful smiling child with beautiful, perfect teeth. It's basically like prevent dental problems is the whole message. And we were thinking like, is this really what's going to resonate with the people that we serve, who most of whom are not children anymore, and many of whom already have oral diseases that are very significantly progressed. So we felt like it might actually be counterproductive to be overemphasizing prevention for our specific population. So we wanted to emphasize recovery as an alternative to just talking about prevention all the time. So we talk a lot in this module about how it's never too late, and that's been kind of part of our approach all along. So this is another kind of sample of our discussion guides. So there in the modules, there are these multiple pause points where it kind of stops and the voiceover says, what would you do in this situation? So in this particular one, it says, a person mentions that a few of her teeth are loose. She has not been to the dentist in many years. She says she figures she will have to get dentures because most people in her family have them. What would you do, and what facts might you share? So when people are taking this module totally self-paced without an instructor, just like finding it online and taking it, it's kind of like more of a reflection for themselves, and we give them materials to read, like facts and ideas like that you see on this slide. But most of the time when people see this e-learning module in Michigan, they're not seeing it just in a vacuum. They're actually watching it as part of a course. So they're watching it as part of their initial peer certification or CHW certification. And so there's an instructor there. And the instructor is given an instructor guide on how to facilitate these discussions and these what would you do scenarios. I think there's 3 or 4 of them like throughout the 2 modules. And so the idea is like this enables the instructor to facilitate a group discussion about an important oral health topic without needing to be an oral health expert. It's like there's no way we could find a dental hygienist to be at every single peer certification in Michigan. It would be like totally impossible. So the whole idea behind this is like we wanted the e-learning modules to provide the concrete support that the instructors would need in order to effectively have a discussion about oral health without needing to be an oral health expert themselves. So accessing the modules, if any of you wants to see them or incorporate them into anything that you're doing, you could do so. They can be accessed through MSHWA's education registry, and this is the website, mshwa.org, or directly through their YouTube channel. So there's going to be some differences in what it looks like in these two scenarios, though, because if you access it through MSHWA as like a continuing education course, you'll have access to materials, like handouts and things like that. And CHWs in Michigan can get credits, like CEU credits, for attending. If they're accessed through YouTube, obviously we can't, there's no place to attach a handout or materials or resources like on YouTube. So it's just the modules in those cases. You don't really get any resources or support in terms of how to facilitate a discussion. You just see the modules. So, we wanted them on YouTube because we felt like that would increase access to the information, and we wanted people to have access to the information as much as possible. But I think overall, as a learner, people are better off going through MSHWA and going through the CEU process, because you get more support, you get more materials, it's more of a complete course. That being said, when this is being used by an instructor within a certification course, whether that's peer or CHW, typically they just play the YouTube modules. They'll pull up YouTube, they'll click play, and they'll pause at the pause points. They'll facilitate the discussion. They don't really need the extra packaging because they themselves are providing the resources and materials and support. So this is information from our program evaluation. We evaluated the program for several months. And so this was a demographic information about who took our course. We were very happy to see that there was a nice mix of trainees who were in their initial peer or CHW certification versus continuing education students. So there was a nice mix of those. And the vast majority of people had none or 1 hour or less of oral health training in the past. So these are just some of the results. Pre-training, so before they took our training, 93% of respondents agreed or strongly agreed that community workers / peer providers should provide people with information or support on oral health topics. But only 12% reported feeling well prepared or very well prepared to provide oral health support. And only 23% reported planning to do so often or very often. So very significant changes took place after our training, with 87% planning to discuss oral health topics often or very often, and 79% feeling well prepared or very well prepared to do so. At the 3-month follow-up, so we actually evaluated the program twice, once immediately after the training and once 3 months later, because we wanted to know, do people feel like the gains are maintained over time, and what feedback do they have about the module 3 months later, now that they've been in practice and they've had a chance to try out some of these ideas with the people that they serve. So preparedness to provide oral health support declined relative to immediate post-training levels, but still remained significantly improved relative to the pre-training, with 53% reporting feeling well prepared or very well prepared. So what this teaches us is that this regression, in their ability to feel prepared, means that they were struck with the complexity of a real client and figuring out, how do I discuss these topics with this person? So immediately after the training, people might think, oh my gosh, this is awesome. I learned so much. I can't wait to apply it. 3 months later, maybe they've realized well, maybe I don't remember it that well, or maybe I do remember it well, but I'm still not sure what to say. I don't know what approach to take. And we think that's probably what's responsible for that change. But we felt good about the fact that people still felt like their preparedness really was improved relative to before our training. And we were very happy to see that 64% of people reported actually discussing oral health topics often or very often with the people that they serve, which is really very much higher than the 23% we saw before the training. So we're excited to see people were actually putting it into practice. This is just another breakdown of some of our results. People were better able to identify correct aspects of oral health literacy. So basically our trainees' oral health literacy improved. They valued fluoride more, they valued baby teeth more. And the result that I loved the most was that after 3 months, 73% agreed or strongly agreed that the modules resulted in changes to how they did their work. We were really excited to see this. So this is just a visual representation of some of our results here. Pre-training, post-training, 3-month follow-up training. So the next steps that we're going to do as a team, now that we've done and evaluated these modules, and we have a paper now forthcoming in the Journal of Public Health Dentistry that talks about this project. So we're really excited to get an academic publication out of it too, in addition to having an impact on practice. The next thing that we're doing now, and this is a project we're right in the middle of, is called the Peer Oral Health Initiative. Our funders are the Delta Dental Foundation and the University of Michigan Depression Center. And what we're doing is we're designing and evaluating a brief peer-delivered intervention. So this time, actually, we're not focusing on CHWs. This is more focusing on peer providers, so peer specialists and peer recovery coaches. We designed a brief intervention related to explaining to people the importance of oral home care habits and connecting people to dental care, and then testing it out. So seeing how this actually works out, because we were thinking about that regression that we saw after 3 months. Not everyone feeling like they know how to apply the material just because they learned it in the training doesn't mean they know what to do in practice. And so what we're doing now is we're supporting people's ability to do it in practice by giving them a structure in terms of here's what you can talk about, here's some topics to cover, here's some strategies to use. So they deliver a brief educational module on oral health. They link the people that they serve to a local source of dental care, whether that's at a health center or a sliding scale clinic. They follow up with people and they troubleshoot any barriers to the appointments that might be coming from social determinants of health, like transportation, or any low motivation or hopelessness or discouragement. That's really where peers can shine. They can really help people get over their sense of low motivation or hopelessness by inspiring a sense of recovery. Since I know in terms of peer practice, self-disclosure and telling one's own story is such an important aspect of peer provider practice, that we are actually encouraging the peers doing this project to self-disclose their oral health recovery story. And many of them have them. A lot of peers do have their own recovery story when it comes to oral health. So, I never want to push a peer provider into disclosing something they don't feel comfortable with. And this is something with a lot of stigma and a lot of pain and unhappiness attached to it. So we always basically say, if you're comfortable, if you want to share, then you're welcome to do so. This is a picture of some of the materials that we developed, and we did this in partnership with a company called Macmillan Health, and they focus on oral health education for communities. So they have these wonderful graphic designers and stuff that worked with us on creating materials like this. And so what you see here actually in practice looks like an A-frame, where the text side, the text heavy side on the left, is the peer facing side. And then the big graphic with just a few words is the side that faces the consumer of services. And so it looks like this, and they can sit next to each other, and the peer provider would use, they don't have to read the script like a robot, but they use the script to guide the discussion. And then the consumer of services would be on the other side and be able to look at the graphic. We also produced a bunch of videos of people telling oral health recovery stories and discussing the importance of oral health. And again, I think I will have time. I will have time to show you some of those videos and get your reactions to them. This is my Stories of Stigma video, and I think I will show this video to you now. I have to navigate to this page because my video software wasn't working on my computer. So let me show this to you now. I'm going to share my screen in just a second. Hopefully you all can see this. If someone can unmute and let me know if you can hear after I click play, I would appreciate it.
Yes.
Great, thank you.
Yes. Growing even as a child, I had issues with overcrowding. It started off with overcrowding. The overcrowding led to cavities. I had cavities as a kid. I was one of the last kids to shed my baby teeth and get my adult teeth. and which caused a lot of ridicule because they had all done that in the 7th grade and I didn't do it till 8th grade. So yeah, I had to fight with that. But
I didn't smile a lot because I never liked my smile. I never liked my teeth.
When I did stop using illicit substances, there was this whole world that I needed to re-engage with. I remember the day that I was reintroduced from my to my family, and it was prior to my receiving dentures, and just, I don't want to make them sound like bad people because they're wonderful people. They were just so taken aback at my physical appearance, and it only compounded the self-esteem issues that I had regarding my my dental care.
Somebody else talking about a family member or their oral health, I sometimes feel like they're talking about me. That's just kind of how my brain works.
I kind of got picked on a little bit because they were a little buck tooth, and so I would always kind of go like this when I smiled, or would pull a pillow up, or there was something I would cover my mouth with when I would smile or laugh too hard. So I would always cover it.
I had goals and dreams, but I had no teeth in my mouth. And so when I thought about going out to get a job and all, it caused a lot of anxiety, a lot of fear.
it is never too late to address any health issue. As long as you're here, we got time. The only time it's too late is when the lights go out for the last time.
Okay, so that was just a sample of one of the videos that we produced for our peer-led intervention. The peers can play the videos for the people that they serve, and they're also used in groups. So when people, when the peers are running groups, either in the drop-in centers or in community mental health, they can use these videos to facilitate group discussions about oral health and stigma, and how sometimes that's actually one of the biggest barriers to making a change and accessing dental care. So I'm going to finish up my presentation here. Oops, it went all the way to the beginning. Hold on. So to acknowledge our funders, Michigan Health Endowment Fund, Delta Dental Foundation, University of Michigan Depression Center, our wonderful community advisory board of peer specialists, peer recovery coaches, community health workers, Ms. Schwa and MDHHS, and our instructional designers, Susan Buza, and project manager, James Garlick. So I'd like to take the time now to just open up the discussion a little bit. If the Q&A doesn't take very long, I'm going to also play for you guys the YouTube videos of the e-learning modules so you can actually see them and decide for yourself if you might want to use them at some point in any peer-led interventions that you're doing or any peer trainings. But I did want to open it up kind of just from some more discussion and reflection on why it is that oral health is this totally neglected aspect of whole health and the importance of it in mental health services, and see if any of you have any stories that you want to share about people you have served for whom oral health recovery was some part of the work that you were doing or work that they were doing. Any dental stories with people you serve that you would like to share, or any questions for me about peer-led oral health initiatives that you might want to try in your locations?
There's a question that's similar to my question. It says, what are the benefits of oil pulling? Because I was doing oil pulling for a minute, and then you touched on something in the beginning when you said fluoride is a misconception, but I've seen, different reviews about it. Could you just touch on that a little bit more?
Sure. So fluoride is actually one of the greatest public health interventions that took place in the 20th century. Community water fluoridation has probably done more for public health than any, similarly low cost intervention And fluoride is a natural mineral that strengthens teeth. It's so overall, the benefits of community water fluoridation are very high. And we really see some of these social inequities take place when some communities don't have access to fluoride. Here in Michigan, many of you may be aware of the Flint water crisis and the fact that the community water was undrinkable by the community for a period of time, and relying on bottled water for basically everything, you know, from baths to drinking to cooking. And think about the disadvantage faced by people, not just the incredible cost of the bottled water and the inconvenience and the suffering that people went through when they couldn't drink their own tap water and some of their children had already been poisoned by it. But even something so simple as not having access to fluoride might have had really, really significant impacts in this community that we are now, you know, only just now starting to look at and think about. So, you know, fluoride is beneficial. It's better to use toothpaste with fluoride than without. It's also possible to have too much fluoride, but that, you know, it's less common to have too much fluoride than it is to have too little fluoride. And that's kind of where access to dental care comes in, because you can talk with a dental provider about how much fluoride you're getting. Is it too much? Is it too little? But the recommendation we always give, you know, in our e-learning modules is choose a toothpaste with fluoride. And in fact, this is a tip I picked up from Danny, my collaborator. She was like, at night after you brush your teeth, don't rinse out your mouth. She was like, spit it out, like try to spit out all the toothpaste, but don't rinse, because if you rinse, you're getting rid of all the good fluoride. If you just spit and don't rinse, then all night long while you're sleeping, you've got like a fluoride bath on your teeth, and that's good for you. So I was like, wow, that never occurred to me. I always thought you're supposed to rinse after you brush your teeth, but now I don't, thanks to her. So, and to address the question about oil pulling, I'm not at all familiar with oil pulling. And also I'm not a dental provider, I'm a psychologist. So I really can't say. But, you know, here's the good thing about having a dental home, which is that you can ask questions like that to your hygienist or your dentist if you do have a usual source of dental care, which I know is tough because of the cost and because of the low access, difficulty finding a dentist, all of these issues. So great question. Anyone else have any questions or comments or thoughts or any stories that you want to share about people you serve or the oral health needs that you've seen in your community?
You pretty much touched on everything. I feel like in certain communities, you know, even in, it's just really hard to get quality dental care,
Yeah.
you know, even for, like, I should say myself, because I used to work part-time, now I'm full-time, but when you work part-time, you don't have the you know, the care,
Exactly.
yeah, so it's just this is like kind of like a touchy, I don't even know how to say it. It's just like it needs to be where it can be. Like I had Medi-Cal. Even Medi-Cal would take 6 months for like certain crown to be
Yeah.
replaced or whatever. And it's just like, how can we? I don't even know where to begin to get this. You know, I used to always ask my dentist, how can we get this? You know, more, you know, aware, and why it's not as, you know, what is it like? Why it's like a, I don't know, it's like you guys are mad scientists and they're just keeping you guys locked up, you know, like the dental
Yeah.
people. I just don't
I
understand.
know.
It just makes me, you know, I don't know how to, I wish there was a way to get it out more, that this is, like you said in the beginning, that your oral is connected to your mental health also, you know, but also the heart disease and all the other things that you touched up upon. But yeah, just having, even when I was part-time, didn't have the access to dental care. It was really hard, and I had a bad tooth, and
Yeah.
you know, instead of getting it fixed, I had to get it pulled. I got it pulled
Yeah.
out, which is cheaper than, you
Yeah.
know, being able to get it fixed.
Yep.
So
Yep. And I hear that story over and over again, and that is part of the injustice of our healthcare system. And
exactly.
these tiers, like these different tiers of care that you get based on how much you want to pay. So
Hmm.
it's, you know, it's one of these systemic injustices that oral health is like very much tied up with, those systemic injustices. But you know, I feel more optimistic when I look at the work that the peers are doing here, because, you know, in terms of how touchy it is, I think you're absolutely right. And then who better than a peer to have this sensitive discussion with people? It's very hard to know how to bring it up. And in fact, the peers we've been working with are vastly prefer doing it in a group setting than individual, because people feel so embarrassed when it's one-to-one. And in a group, somehow it's like a little bit more casual. It's more like a class. It's less about, one individual and their quote unquote problems. And it's more about, here's an issue that many people face. So we're actually going to like test out a group version of this next. It's kind of like what we're hoping to do.
Yes.
Did you ever think too, though, like how weird it is that we have dentistry to begin with? Like, why is it not a medical subspecialty, just like dermatology or ear, nose, and throat, or, neurology? Like, we have brain doctors, we have throat doctors, we have foot doctors. Why don't we have tooth doctors? And, it turns out this is all basically a historical accident that happened in the early 20th century, where medical schools and dental schools decided to separate, and they've been separate ever since. And it's like the most illogical thing imaginable. I mean, just like, these carve outs and these separate funding streams, and this is covered and this is not covered, and primary care doctors have nothing to do with the mouth. It like causes so many problems for it to be separate professions. If they were just regular doctors, like any other specialty, then we wouldn't have a lot of the problems that we're facing now.
I agree with you 100%.
Does anyone else have any like comments or stories or thoughts about, the health equity perspective, or what you've seen personally among people that you serve?
I had a client who, I don't even know where to start, but her teeth were like everything to her, her smile, like, and so long story short, with her history of drug use, and then finding out that she had a broken jawbone or something. And so even though she had dentures, it's still like, I don't know, she's just still so adamant about like how her face is still sucked in, and there's still like, she still doesn't have that like that normal smile. And so it affected her mental health tremendously. Yes. Like a lot of the holds were because of just dealing with that. She could not accept it. She could not move forward. And it was really sad, like really sad. Plus other trauma too, but mostly she would bring that up constantly. If I would just I can't get a job, I don't have teeth, or I have these teeth. But so that really bothered me, and it opened up my eyes a lot to really just think of like how important it is to just take care of your teeth and do those things if you're able to, of course, with insurance and stuff like that.
Yeah. Cleanisha, I'm glad you brought that up, because it's actually true. There's research showing that employers discriminate against people with visibly decayed teeth, and it's very unfortunate. It's it's not legal to discriminate against people on that basis, but for whatever reason in our culture and our society, teeth like somehow represent something to people, like wealth or whatever it might be, health. Like it's hard to know what exactly it means, but for some reason people are so ashamed when their teeth don't look right. And then there actually is documented evidence of discrimination among employers. So, she's actually right in that sense. Like she's not paranoid. Like it's true. She might actually have been discriminated against in terms of getting a job. But it is so sad to see when the stigma is so strong that it affects people's self-esteem. It affects people's mental health. And again, I really see peer workers, peer providers as people who can help have these really difficult discussions with people and help them access care to whatever extent is possible. I know that there is a question in the chat from Ken with the MSHWA peer certification, cover certification, California, not to my knowledge. So I think it's only for Michigan-based peers, but most states do have community health worker programs. Again, it's not necessarily certification, not necessarily sustainably financed, but there might be a California version of MISHWA. And if you Google California Community Health Worker Alliance, you may find that there's an organization already doing some advocacy. Any other questions or comments for me?
I don't know if you touched on this. What else are you guys doing to, I guess, get the word out, or any other, I guess, group activities or something I can volunteer to help? Because I would like to, help with this, because I feel like this is one of the things that, even when I was growing up, there wasn't a lot of consistency in where the demographic I lived in. So if there's something that I can do to volunteer, or any other resources that you guys are, how else are you guys getting the word out about this?
So I appreciate that very much. And I would love to get an email from you. So my email is on the slide, and maybe we can talk back channel about ways to collaborate. Right now, our next step is to try to develop this peer-led intervention. That's kind of what we're working on right now. We're kind of doing acceptability, feasibility right now. We're trying to get a grant to actually test it in research, more of like a trial, and we'll see what happens. But I really think, again, we put these e-learning modules on YouTube because we want people to access them. So if you want to, yes, I believe you will get the slides. If you wanted to think about how to organize, like even just a circle, like not necessarily a training, but let's say you wanted to do just a discussion circle among peers or among staff at your organization about what can we do next about oral health, you can structure some discussion around these e-learning modules if you want to, or just bring up the topic as like, do we need an in-service? Do we need some, more education and support around oral health locally? So, I love that you're interested in doing this, and I hope more people will kind of take an interest. This is kind of like a, all my colleagues think I'm really weird for having like a tooth model on my desk. They're like, what is this? But once you really think about it and realize the way mental health and oral health are interconnected, it becomes almost like a no-brainer. Like, of course we should be working in these areas. So
I think that California does everything last. So if you guys are not doing it in Michigan, I don't know how much longer it'll take. So it's a good idea to start early.
I think of California as so like forward thinking. I don't know, but let me, in just a few minutes left, I want to navigate to YouTube and just show you like just a little sample of what this looks like, and then you can, if you want to watch the whole thing, you can. Again, YouTube is not the ideal place to get the information because there's no resource packet that comes with it, and it's not facilitated by any trainer, but it'll give you a flavor for it. I'm going to skip the ad here. Don't need any more marketing, right?
Or do you think that you're sharing your screen? Because you're not.
No, I'm about to do it. Yeah, thank you.
Just checking.
Yep. Okay. Can you all see my screen now?
Yeah.
All right. Actually, I'm a little worried I may have forgotten to do the optimize. Hold on. Share sound, optimize video. Okay.
An oral healthcare toolbox. In this lesson, we will take a deep dive into the home care habits that support oral wellness. You will learn specific oral health tools, such as fluoride and toothbrushes, that can support oral wellness. You will learn how these tools can be used with proper technique, and you will learn how to teach others about these tools and techniques. What you are about to learn about keeping the mouth healthy might surprise you. even if you've been to the dentist many times in your life. The main take-home message in this lesson is that what people do at home is the #1 factor in keeping their mouths healthy, and that it is never too late to improve oral health. You'll notice a special feature of this lesson is that there are a few opportunities to pause and consider what you would do in particular situations. When a "what would you do" slide comes up, feel free to pause the presentation for individual thinking or a group discussion. Part 1. What are the home care tools? We will learn what the recommended home care tools are and how they should be used to support oral health. One of the most important tools in your oral health wellness toolbox is fluoride. You might have heard about fluoride before, but today we will take a closer look at this important ingredient. Fluoride is a natural mineral that helps strengthen people's teeth and lowers their risk of oral diseases. When used the right way, fluoride is not dangerous. In fact, fluoride is seen as one of the biggest public health successes of the 20th century. People usually get their fluoride from two sources: tap water and toothpaste. Let's start with tap water. Fluoride is added to many community water sources, giving fluoride access to millions of people throughout the U.S. Even so, there are several reasons why people may not have access to fluoridated tap water. There might be problems with the quality of local tap water, which forces communities to drink bottled water instead. Also, some people get their water from a well instead of the tap, especially in rural communities. Finally, some communities are fearful of fluoride and have opted not to fluoridate their water. Fluoridated water helps strengthen teeth enamel when the teeth are still growing, but it can be a problem in high amounts. A dental provider can help with advising patients about the right amount of fluoride for children. Next, let's talk about toothpaste, which is another important source of fluoride. When people brush their teeth with fluoride toothpaste, they are placing fluoride directly on their teeth. Brushing with fluoride toothpaste is a great way to access fluoride. But just like with tap water, there are several reasons why people may not have access to fluoride toothpaste. They might have a low income and need to spend their money on other purchases. They might not realize the value of fluoride toothpaste. And they might have heard from friends or read on the internet that fluoride is dangerous. When working in communities, one of your roles can be to understand the barriers people face in accessing fluoride and to help them overcome those barriers. You can also help people come up with questions about fluoride that they should ask their dental provider. Here is an opportunity to pause and consider what you would do in a particular situation. A person says that he...
Okay, so I think you guys are kind of getting the picture. That module is about 20 minutes long. And the first module, what I was showing you is actually the second module, the one about the toolkit. The first one is more general and about oral health and well-being. That one's about 15 minutes. We kept them short for a reason. Like, we really wanted them integrated into the certification programs. Like, that was our #1 goal, is to get oral health into the initial peer certification. And so we could not do like an hour present. There's no way, like, we definitely have an hour of material, but there was no way they were going to devote a whole hour to oral health. So we had these 2 modules, and depending on the trainer, they might use just one or both. But you kind of get the picture, and you're welcome to use them. They're publicly available. And again, if you want to think about having a circle or a meeting or an in-service or something with your agency where you can center it around these modules and say, what more can we do for people's oral health? And you're welcome to it. And feel free to reach out to me directly if you have any questions about using them or what your next steps might be.
Thank you
I know
so
we're
much.
almost out of time here, but I just wanted to thank everybody for listening.